you, يا خالد.
دكتور
If you
جون،
want
لا
to
في واحد
know
بس فتح المايك. في واحد فتح المايك ممكن تسمع.
شو بدك تسأل؟
لا ما في سؤال دكتور.
ما في. طيب خليني اقول لك if you want to know more about the head you can do an arthrogram. Look at the cartilage of how well it appears. But in the previous x-ray it was a flat head. لا, the cartilage is continuing to grow. So we like to catch these cases early before you know that cartilage is soft. If it remains subluxed, then you'll have a deformity. For this reason, we speak a lot about containment. Okay, the arthrogram shows you the boundaries of the cartilage, which obtains its nutrition from the synovial fluid. It does not need vascular supply to survive. So keep this in mind. By undergoing metaplastic change, the resultant cartilaginous anlage has the biologic capacity to initiate endochondral vascularization and ossification. That is what I spoke about page 3. Reossification. Okay? We can have reossification and remodeling. This important feature of Legg-Calve-Perthes disease is the principal factor that differentiates it from less efficient and often futile revascularization and ossification through the process of creeping substitution, which is observed in osteonecrosis without metaplasia and is seen in older children and adults. By stating this, we are separating avascular necrosis of the hip in a child from that of an adult. In the adult, you need creeping substitution to undergo whatever reformation of the head is taking place. In children, the main supply of support comes in from the metastasis, from metaplasia into the area, and from whatever process of new bone formation. The pediatric hip has a substantially greater potential for revascularization of avascular areas, which effectively resets the hip back to a stage in development at which the epiphysis was largely a cartilaginous anlage before ossification. What about reossification? Stage 3 is directed by revascularization. I repeat, by revascularization of the capital epiphysis, and the method by which this occurs and whether it is complete directs the disease severity. Now, at this point, I would like to mention something. Maybe you might find it out of the topic now at this present. You have to realize that Legg-Perthes disease is an avascular process. It does not occur from one attack alone of avascularity. It occurs from several attacks. And this distinguishes it from, for instance, other conditions like epiphyseal dysplasia, like Gaucher's disease. They are symmetrical. In Legg-Perthes disease, we have several attacks at different stages. Keep this in mind. We like to ask that question. In what way is it different? The following 3 main outcomes exist regarding revascularization. revascularization without consequence, where the hip nearly returns to normal, revascularization with consequence, and incomplete revascularization. Anatomically, restoration of the blood flow to the epiphysis may occur through creation of periphyseal vessels, which spare the physis, maintains segregation of the metaphyseal and epiphyseal blood flow, and lead to the maintenance of the characteristic proximal femoral geometry. Alternatively, injury to the physis during the first two stages of the disease can promote channels of vascularity through the physis, leading to premature ossification across the physis. And as a result, they get a physeal bar formation. This we don't like it to have. This would cause significant deformity of the head and incongruency of the head with respect to the acetabulum. So keep this in mind. With a healthy physis and periphyseal revascularization, the hip may remodel into stage 4 in the plane of motion, which results in a hip with relatively little deficiency in motion. And actually, Stulberg's classification is what this classification describes well of whether the deformed hip has regained its normal shape or a bit less. Alternatively, revascularization via physeal bar formation impedes, I repeat, it impedes the ability of the hip to remodel and may instead propagate further geometric changes in the proximal femur. The role of the bar formation, of the physeal bar formation in the overall deformity leads to femoral head widening, coxa magna, widening of the femoral head, flattening, coxa plana, a shortened neck, coxa breva, and relatively overgrowth of the greater trochanter due to the intact physis or apophysis, while in the head, the physis is obstructed, the growth secondary to a bar. The outcome is ultimately associated with the resultant geometry of the femoral head and the condition of the articular cartilage of the hip. So, over here, if you have containment, you have nearly normal, you have normal head geometry. If you don't have a physeal bar, it might block growth, and you will have all the findings I spoke to you about coxa magna, coxa breva, and you could even have impingement secondary to femoral acetabular impingement. You have dysplasia of the acetabulum, and all depend on when you get the revascularization, if it's well contained, the hip, and the proper age, it will remodel to normal. Although healing occurs in many patients with little or no permanent change in the morphology of the femoral head and acetabulum, long-term studies have shown that a substantial change develops in approximately 50% of patients, which leads to premature degeneration or degenerative joint disease and disability. Factors that are known to negatively influence the resultant geometry is never forget loss of containment and the presence of a physeal bar. factors that are known to negatively influence the health of the articular cartilage. Again, never forget femoral acetabular impingement and for subluxation and extent of revascularization of the epiphysis. Now we come to classification and imaging. I know I might be boring you, but we are tackling the subject of Legg-Calve-Perthes disease from A to Z. A bit about the catarrhal classification. You have to know the head at risk signs. You have to know what is the catarrhal classification. The catarrhal classification classes them into 4 types. We know that the first zone is a localized zone in the anterior superior lateral portion of the head. That's 1. Type 2, it becomes more involved, the avascular necrosis. In type 3, there's only 1/3 of the head or less that is not avascular. And finally, 4 is the stage of adjustment, the remodeling phase, the congruency, etc. So I would like to mention these points. In the catarrhal classification, we have head at risk signs that tell us we're going to have a bad result. First of all, as I mentioned, you see, I did not give these classifications at the beginning. I'm giving them now so that you can apply to what I told you about. The head at risk sign, what gives us a bad result? Lateral subluxation. You see that there is lateral subluxation. You see it if you have also speckled calcification of the lateral end of the capital epiphysis. If you have diffuse metaphyseal reaction or metaphyseal cyst, here's a metaphyseal cyst. This tells us there's a bad result. We know that normally the physis is oblique or nearly towards the vertical aspect. When it becomes horizontal, the prognosis is bad. And if you look at the neck, you see that if you compare it to the opposite side, you see that you have a widened neck. And don't forget about the zone of radiolucency between the epiphysis and the metaphysis, the radiolucent zone, which is known as gauge sign. It's a radiolucent V-shaped defect in the lateral epiphysis and adjacent metaphysis. So please don't forget, these are the head at risk signs that we usually follow. The first widely used classification was a study published in 1971 by Catterall. He based it on a series of 121 patients with 133 hips with a diagnosis of Legg-Calve-Perthes disease at the Hospital for Sick Children, Great Ormond Street in London. Among them, there were 46 hips that were untreated. The treated cases were carefully matched with the controls, and it was found that there was little difference in the overall results between the groups. Catterall noted different radiographic courses among the different degrees of development of the disease. He used, let me see where I have this covered. I want to see what is this. Yeah. He used the SUNT outcome criteria and put it into good, fair, and poor in his study. The description of radiographic pathology was very detailed. He classified Legg-Calve-Perthes disease into 4 groups on the basis of the anterior, posterior, and lateral radiographs of the hip, with additional arthrograms in 59 cases. He used the SUNT outcome criteria. So you have to realize this. Group 1 is only the anterior part of the epiphysis is involved without collapse, and complete absorption of the involved segment occurs without sequestrum formation. This is group 1. You see that it's a localized form. It's around 1/3 of the area of the epiphyseal ossification center, and it involves the anterior superior portion. So this is group 1, and it is shown very well on the lateral view of the right hip, shows that only the anterior part of the epiphysis is involved without collapse and sequestrum formation. So don't forget, this is stage 1. Metaphyseal changes are unusual in the early stage. The course of the disease seems to be absorption of the involved segment followed by regeneration. Group 2, rather more anterior part of the epiphysis, is involved with collapse of the segment after the initial phase of absorption. In the anterior posterior radiograph, the sequestrum appears as a dense oval mass with viable fragments on both the medial and lateral sides. So the center, the segment is involved, but you have viable fragments on both sides, medial and lateral. On the lateral radiographs, the sequestrum separated posteriorly from the viable fragments by a characteristic V. I'll show it to you. Now, if you look at this lateral view, you see these are viable bone. Over here, it's viable. This is the dense bone. This is the sclerotic bone. This is the avascular bone. And you have a sequestrum which appears as a dense oval mass with viable fragments on both medial and lateral sides. This is the sequestrum. These are viable. This is viable. This is category 2. Group 3, in this group, only a small part of the epiphysis is not sequestrated. And this is what Salter used to say always. It gives you a head in the head appearance. The antero-posterior radiographs show a head in the head in the early stages. The central sequestrum collapses and appears in later stages with small normal segments on the medial and lateral sides. Now let's see what this shows. The lateral fragment is frequently small and osteoporotic. Only a very small portion of the posterior part is not involved. Metaphyseal changes are more generalized and extensive with broadening of the neck. And this is the category 3. You see that there is an antero-posterior and lateral view of the right hip. It shows that only a small part of the epiphysis is not sequestrated. You have a central sequestrum, collapse. It appears in the later stages. The lateral segment is small and osteoporotic. Only a small portion of the posterior part is not involved. Group 4, the whole epiphysis is completely sequestrated and collapsed, and early loss of height between the gross plate and the acetabular roof indicates head flattening. This shows you the total involvement is head flattening. These are well demonstrated on the anterior, posterior, and lateral views of the right hip, which shows that the whole epiphysis is sequestrated. With displacement of the epiphyseal fragment anteriorly and posteriorly, it produces a mushroom-like appearance of the head. There is no posterior viable portion on the lateral radiograph, but the epiphyseal changes are also extensive. We have the Salter and Thompson classification, which found that the extent of the subchondral fracture correlated precisely with the subsequent extent of maximum resorption of the femoral head. This is shown on the lateral view. You have a lateral X-ray, and you see this subchondral translucency over here. They determined that subchondral fracture is of prognostic significance in predicting the eventual involvement of the femoral head. After classification using category, grouping, and checking the final outcome, they proposed a two-group simple classification on the basis of the extent of the femoral head involvement of subchondral fracture. This is a lateral view of the right hip, which shows the extent of the subchondral fracture in the anterior part of the femoral head. Group A is less than half of the head involved, depending on the extent of the subchondral fracture, and group B is more than half of the head is involved. This is called the Salter-Thompson classification. It's nice to know, and you have to tell that it tells you what stage the patient is by just studying the crescent sign or line. Finally, we come to the lateral pillar classification. The lateral pillar classification tells you it was devised by Herring, and this is a Herring A, where this zone of the lateral epiphysis remains of the same height. In B is where it collapses and lies between 50 and 100%. In C, in BC, likewise, it is around 50% exactly of collapse, while C, which is the worst prognosis, where you have more than 3/4 of the epiphysis is gone, and there is less than 50% collapse. In 1992, Herring et al. Published a new classification, and he called it the lateral pillar classification. He based the study on 93 hips in 86 patients with radiographic follow-up to skeletal maturity. The final outcome was determined according to Stulberg et al. Classification of the shape or the final shape of the femoral head. He divided the femoral head into 3 parts: lateral, central, and medial pillars, as is shown in the sketch that I showed you at the beginning. The determination is based on the true anteroposterior view of the hip. The greatest involvement of the lateral pillar in radiograph was used for the classification. Group A, there is no involvement of the lateral pillar with the full height maintained. The medial and central pillars may have lucency and collapse, but the lateral pillar is still intact and not collapsed. This shows you the lateral pillar, which is group A in the Herring classification. This is an anterior posterior view of the right hip, which shows a central lesion without involvement of the lateral pillar. You have a central lesion without involvement of the lateral pillar. There were no density changes and no loss of the height of the lateral pillar. Group B, there is greater than 50% of the lateral pillar height maintained. You have to keep this in mind. It is greater than 50%. The lateral pillar may have some lucency with maintenance of the bone density at the height between 50 and 100% of the original height of the lateral head. The height of the central and medial pillars may be partially or completely decreased. This is a lateral pillar B. You see the height of the lateral column is more than 50%. It lies between 50 and 100% of the original height. You can see that there is lucency of the central and medial portion. Group C, there is less than 50% of the lateral pillar height remaining. The lateral pillar is more loosened, and the remaining bone is less than 50% of the original height. The degree of decreasing height of the medial and central pillars may vary. Lateral pillar group C shown over here. You see it's completely collapsed, and this is shown in the anteroposterior view. You see it's definitely loss of height, okay? And greater than loss of height. So keep this in mind. Now, BC was created later, and they modified their classification and published an additional article in 2004, adding an intermediate group, BC border, which includes a femoral head with a thin or poorly ossified lateral pillar and with a loss of lateral pillar height at 50%. They stress that 50%, not more, not less. This is BC. This is a AP view showing you the BC group. This is an anterior posterior view. And the right hip showed a very narrow lateral pillar, 2 to 3 millimeters wide. That was 50% of the original height with some lucency and depressed relative to the central pillar. With the addition of this group, there was greater inter-observer and intra-observer reliability than previous classification systems. This goes to show you more and more into A, which the lateral pillar is well maintained. B, it's between 50 and 100%. C is less than 50%, and BC is 50% height of the lateral pillar. The final outcome of this group of patients using the Stulberg classification showed that Group A had a uniformly good outcome. The Group B had a good outcome if the patients were less than 9 years old, but was less favorable if patients were older than 9 years at the time of onset of the disease. In the Group C, the majority of femoral head became aspherical in both age groups. For the early sign of Legg-Calve-Perthes disease and its progress, scintigraphic evaluation is another method of studying Legg-Calve-Perthes disease. It is cited that radiographic appearance of avascular lesion is always already late in the diagnosis of Legg-Calve-Perthes disease. Classification systems are based on the radiographic course of the femoral head. Waldenstrom's divided the disease into 4 stages, as I had mentioned. The lateral pillar classification should be applied cautiously in the early fragmentation stage because progression to a group other than the previous assigned group can occur in up to 75% of hips initially classified as herring lateral pillar group A. 21% to 33% of hips are ultimately assigned a more severe group later in the fragmentation stage. The most widely used system for outcome measurements of Legg-Calve-Perthes disease is the Stulberg classification, which categorizes the mature hip into 5 classes. The Stulberg system is based on the shape of the femoral head and its congruency and has been shown to predict degeneration. The reproducibility of this classification was improved by pooling class 1 and 2 hips and class 3 and 4 hips. This is the Stulberg classification. In class 1 and 2, you have a spherical congruity. Arthritis does not develop. In class 3 and 4, you have mild to moderate arthritis, and this occurs in mid to late adulthood, and aspherical incongruity in class 5, where you end up with severe osteoarthritis before the age of 50, and many of these end up by having a total hip replacement. Visual assessment of the degree of femoral head deformity in Legg-Calve-Perthes disease is unreliable, and most authors have advocated for a more objective classification. A new classification has been developed that relies on digitalized imaging to determine the sphericity deviation score, the extent of enlargement, the composite femoral congruity arc of the femoral head in final outcome. Intra-observer and inter-observer reliability were found to be good to excellent for all measures, and good correlation with the Stulberg classification also was reported. The role of advanced imaging in classifying and predicting outcomes in Legg-Calve-Perthes disease remains unclear. Recently, there has been substantial interest in the use of early diffusion MRI for making a prognosis. In a 2014 study, 31 hips were imaged and classified using the herring lateral pillar system. A diffusion MRI was obtained when the patient was first treated and again when the fragmentation stage was reached. The apparent diffusion coefficient of the metaphysis correlated with the herring lateral pillar classification as early as the condensation sclerotic phase, but more studies to elucidate its role in prognosis beyond plain radiograph remains unsupported. So enough for diffusion MRI. Now the residual deformity, including femoral acetabulum impingement, can occur and is best characterized on axial imaging and dynamically by arthrography. clinical presentation, we all know that the age of onset of symptoms and duration of the disease must be determined. The exact age of onset can guide the planning.
الدكاترة الخط قطع من الدكتور جون، نحاول نتواصل معه.
بين كل شيء هلا؟
اي واضح
واضح. Okay, يلا. As I was mentioning, a history of passive smoking, which should be evaluated as maternal smoking, at least one smoker living in the child's household. So I tell you, you people who are having children, يلي بتدخنوا، وهيدي موجه لخالد يلي بدخن وحواليه أولاد. We found that there is a higher incidence of Legg-Calve-Perthes disease in these families. Even إذا مولع شمني وعم بيطلع دخنة، كمان this would lead to a higher incidence of avascular necrosis in these children, which was concluded by several studies in families. The child with Perthes disease limps and complains of occasional pain in the groin, hip, or knee. One of the questions we love to ask in the board exam, why is it that when you have a problem in the hip, the pain is referred to the knee? You should know that there's a nerve, the obturator nerve. It supplies and becomes a saphenous nerve around the knee. And this is referred pain from the hip. So every child who comes to you with pain in the knee at an age in which you should think of Legg-Calve-Perthes disease, you should look for hip pathology. You should always examine the child as a whole. You should always examine the hip, examine the knee, examine the feet. These symptoms may be present for weeks or even months, and nobody realizes. They all say it's the knee when the problem is in the hip. The examination shows a mild limp and decreased range of motion in abduction and internal rotation. All you need to do is put the patient on his back or supine position, flex the hip, and internally rotate the hip. If there's limitation, then you should wonder, is there pathology of the hip? If there is limitation of abduction, likewise. So keep this in mind. Occasionally, there may be gross limitation of all range of motion. Persistent hip stiffness is a poor prognostic sign. It is essential to gain normal range of motion of the hip joint before considering containment treatment. In the past, what did we used to use? We used to use the P3 cast a lot, but we used to bring the patients, examine them. If they had stiffness of the hip, we would put them in traction for 1 week at home, and they will bring them back, examine the hips. If the range of motion improves and continues to improve, then we do our treatment and put them in the cast. You should never try and contain a hip in a spastic hip in a patient where there's limitation of motion. Please keep this in mind. Plain radiographs, anterior, posterior, and prog-lateral, are useful to diagnose the stage, the extent, and the severity of involvement of the femoral head. The sequential changes of natural history can be divided into two groups. You have the active disease and you have the healed disease. Disease is considered active when the capital femoral epiphysis looks sclerotic with or without the presence of collapse and reossification. Don't forget these. The disease is considered healed when no remnant of avascular bone can be identified or on both views. Contrast enhanced magnetic resonance imaging can clearly define the area of the involvement of the early stage of the disease. Active stage of the disease, early stage of the disease is important to identify. The femoral head is subjected to deformation in the late stage of fragmentation or soon after this stage. So the active stage of the disease is divided into early and late stages. The early stage refers to the stage between early avascular necrosis and early stage of fragmentation. The late stage refers to the stage between late fragmentation and early reossification of the capital femoral epiphysis. Don't forget this classification into early and late stages. You have to know what stands for early stage, what stands for the late stage. The management, the age of the child at onset of symptoms, the extent of involvement, the stage of the disease, the range of motion of the hip, the presence of extrusion of the femoral head, all these will help you in deciding what type of management the patient needs. The age of onset can be further divided into less than 5 years, 5 to 8 years, and 8 to 12 years. So you have to know these points. And if the child is more than 12 years, you'll have adolescent-Perthes disease. Adolescent-Perthes disease behaves differently from the early onset of Perthes disease. Non-surgical treatment is effective and indicated for children who are young. I repeat, non-surgical treatment. ما بسمع. خالد شو القصة؟
عفوا دكتور، بس في مايك افتتح. عفوا دكتور.
بس انه ما في معركة.
لا
طيب. Non-surgical treatment is effective and indicated for children who are young. Don't forget this. Less than 5 years. If you treat them conservatively and you treat them early, then the result is definitely much better than when you treat them late. We spoke about containment so much, but surgical containment. Containment refers to repositioning of the anterolateral part of the femoral epiphysis within the confines of the acetabulum to protect the femoral head from being subjected to deforming forces. We like to cover the head so that we won't get hinge abduction, so that we won't get any impingement, because all these lead to late osteoarthritis. Containment can be done by casting, by bracing, of femoral or innominate osteotomies. Non-surgical containment, you can use an abduction cast. One that we have used often is the Petri cast and the brace. But the problem with these are the cast is preferable to the brace. And why don't we like to use the brace so much is that if you get in non-cooperative woman or mother where she removes the brace, then you are harming the patient. Various types of orthosis, abduction splints are available. Rich and Schonecker recently showed excellent results with an A-frame orthosis with hip range of motion. The disadvantages of the brace are that it requires excellent patient compliance and must be worn for a longer period of time. These are the various braces that we use. You have a Toronto brace, you have the Atlanta brace, you have a brace where you just abduct the hips, you have a Petri cast, you have various types of brace. But the Atlanta brace, we used it quite a lot. But if you look at the photo below, you see that the patient's knees are externally rotated. They're not internally rotated, which helps in coverage of the head of the femur. Okay? Now, an abduction orthosis is preferred for children less than 5 years who present with extrusion. An abduction orthosis and cast treatment are tedious and psychologically difficult for the older child. More than 5 years. The author does not use any brace or splint as a definitive treatment for children older than, and the problem here, older than 5 years of age. I'll tell you, this is something you have to realize, that these children after the age of 5 are not cooperative. They can remove the brace and you not know about it. And as a result, they will have more and more impingement, and they'll have more and more destruction or more and more deformity of the head. A typical child with Legg-Calve-Perthes disease will have a limp. In the early stages of the disease, the limp may or may not be associated with pain in the hip, and radiographs may appear normal. So you have to keep this in mind. So I'm going to go rather quickly. Just this point, during the reossification stage, there's little pain, but improvement in motion depends on the residual deformity. Musculoskeletal infections, including proximal femoral osteomyelitis, septic arthritis, pyomyositis, should be ruled out in all patients who come complaining of hip pain or a limb or referred pain to the knee. You have to keep this in mind. Slipped captate femoral epiphysis may also be included in the differential diagnosis in older children. Bilaterally, it suggests the possibility of epiphyseal dysplasia, as I mentioned at the beginning of the lecture, sickle cell disease, Meyer's dysplasia. Meyer's dysplasia is an innocent condition where the hip, though fragmented, it resumes its normal appearance with time. Gaucher's disease is a metabolic disease. It's quite common in the Jews, and Usually it attacks both sides at the same time. Hypothyroidism, you have to keep this in mind in the differential diagnosis. It is important to recognize that Legg-Calve-Perthes disease may involve bilateral disease, but at different stages of the disease are likely to be seen in each hip. Treatment and outcomes, we spoke about a good part of the condition. Now, what has gone here? Something has gone. So, I would say Khalid, يا خالد.
اسمعك دكتور.
ليه راح الصورة خالص؟ غريب.
طب ممكن يا دكتور تعيد السكرين شير مرة ثانية؟
لا برجع insert it again. اوكي. غريب. راح يا خالد
اسمعك دكتور.
حاطين لي host disabled participant screen sharing.
دقيقة يا دكتور بس. اوكي الآن ستارت.
برجع بعمل.
الآن ستارت.
شايفين هلا؟
واضح يا دكتور.
واضح لك. ماني عارف شو صار. محى كل اللكشر تبعي، التزمت جيبه من غير محل، ما بعرف مين محل اياه. على كل حال في شيء حدا hacked it and took it. يا جماعة, I just would like to terminate this portion of my lecture in what we're doing these days. These days, we're exposing the head, we're removing the deformed portion of the head, and we're doing a mosaicplasty on the head. Or if the central portion of the head is destroyed, we're removing the central portion and bringing the lateral and medial portion of the head together. These are new techniques. Look at this is the mark. We marked the area where we're going to do the mosaicplasty, and we make our mosaicplasty in the place where there's no more any cartilage and it's destroyed, and then we do our mosaic on the head. And the results are reported. They're still not definitely, but they report them to be good results. Fast to know this. This is just for you to know. And now I'm going to go into my next lecture. The important thing is that you should know that the patients who have a deformed head, who end up with Stulberg, let's say 3 and 4, these are the patients that at an early stage, they need a total hip at around the age of 50. These are very important. So the key study points are the etiology of Legg-Calve-Perthes disease is likely caused by the unique characteristics of blood supply of the femoral head in children and multifactorial localized ischemia. That's one. The goal of treatment in Legg-Calve-Perthes disease is to minimize geometric deformity and maintain congruency of the hip as revascularization occurs and the hip progresses through the stages of this condition. The chronic deformity associated with Legg-Calve-Perthes disease represents a complex problem that often eventually progresses to osteoarthritis. Now is our second topic. Are there any questions concerning Legg-Calve-Perthes disease? شو خالد؟
اسمعك دكتور. الشباب اللي ناوي يسأل يحط الكويشن على الشات.
حطوها على الشاشة. خلينا نشوف إذا في شيء على الشاشة. Okay, so I'm going to leave it at the end, and I don't see any questions over here. Okay, so we'll start with femoral acetabular impingement. Femoral acetabular impingement is a condition that characteristically presents with hip pain, secondary to mechanical impingement from abnormal hip morphology involving the proximal femur and the acetabulum. With hip rotation, the extreme arcs of motion, or when there is repetitive abnormal contact between the bony prominences, this leads to soft tissue damage of the femoral acetabular joint. So one is the bony prominence. Two is the soft tissue, which consists of the labrum, tethering of the labrum. This occurs secondary to impingement. Over time, this chronic repetitive trauma can lead to hip pain and decreased function. We're going to see what is this. The abnormal bony features include a cam deformity of the femoral neck junction, as well as pincer lesions of the acetabulum. Cam deformity is an abnormal bony prominence or bump at the junction of the femoral head and neck, resulting in an aspherical shaped head, occurring most commonly along the antero-superior femoral head-neck junction. You can see this. This we get quite often in patients who have Legg-Calve-Perthes disease. We see it in patients who have a slipped capital femoral epiphysis or any fracture that leads to this malposition, this protrusion on the antero-superior portion of the head, which is called the cam. This, as a result, can impinge on the outer margin of the acetabulum, leading to tethering and the pincer lesions of the acetabulum. You can see it in the X-ray beneath. On the right-hand side, you see the cam, and this impinges on the outer side of the acetabulum. This can also occur in version of the acetabulum. An acetabulum which is retroverted can impinge and lead to this tethering and lead to the problem. Another point is you have to think of anything that that you end up with a protrusio acetabuli or a profunda. All these can impinge and lead to femoral acetabular impingement. A pincer lesion is an abnormal bony overhang of the anterolateral acetabular rim, resulting in overcoverage of the femoral head, which can also contribute to impingement and pain. Both cam and pincer lesions are visible on plain radiographs. Patients may present with either one or both or mixed morphologies, with the mixed morphology being the most common in symptomatic patients. When impingement occurs, it results in mechanical collision of the femoral cam with the rim of the acetabulum, which results in pinching of the labrum and cartilage. Over time, this can result in cartilage wear and tearing of the labrum. As a result of labral cartilage injury, femoral acetabular impingement can lead to hip osteoarthritis over time. The diagnosis of this condition is dependent on the history, physical exam, and radiography of the hip and pelvis. Treatment typically consists of initial non-operative measures. However, if conservative management fails, then there should be consideration of surgical management by an orthopedic surgeon. What about the etiology? The formation of femoroacetabular impingement has also occurred in patients with the history of slipped capital femoral epiphysis. When this primary insult happens during childhood, the epiphysis of the femoral head slips posteriorly and medial respect to the metaphysis, leading to a prominent metaphysis anterior and laterally, and this would lead to impingement. Even after surgical in situ fixation of a slipped capital femoral epiphysis, there is a residual deformity, and this can cause impingement. The prevalence of femoroacetabular impingement in the general adult population is between 10 to 15%. Based on clinical diagnosis, femoroacetabular impingement affects adolescents and the young adult population before radiographic signs of arthritis manifest. The prevalence of symptomatic athletes has been reported to be higher than the general population at 55%. There is also literature that has examined the prevalence of anatomic morphology consistent with this condition, but in asymptomatic individuals, therefore patients can have bony features of femoroacetabular impingement and not manifest with symptoms. So not all these patients who have a CAM or a pincer might have symptoms, but the far majority do. A meta-analysis by Frank et al. Reports a prevalence of 37% for CAM deformities and 67% for pincer deformity in asymptomatic volunteers. When accounting for the athletic population, CAM deformity prevalence was 54.8% for athletes and 23.1% for non-athletes. The pincer lesion was present in 49.5% of the athletic population. CAM deformity is more prevalent in men than women, with a reported prevalence of 9 to 25% men versus 3 to 10% in women. Pincer lesions are more common in women than men, with reports of 19.6% versus 15.2%. So pincer is more common in women, CAM more common in men, and more common in athletes. Obtaining a thorough history is essential for identifying a diagnosis for hip pain. Inquiring about a history of trauma, infection, slipped capital femoral epiphysis, Legg-Calve-Perthes disease, hip dysplasia, osteonecrosis, sporting activities, and any other hip pathology is essential for the workup. Femoroacetabular impingement characteristically presents with a gradual onset of hip pain. They occur in younger individuals, and it's often exacerbated by hip flexion and internal rotation. Activities such as high-intensity sports, squatting, driving, and even sitting for prolonged periods may provoke hip pain. If a patient presents with acute hip pain, a workup for other causes is necessary. They usually don't have acute hip pain. It's a gradual process. Clinically, patients will present with groin or hip pain anterolaterally that may radiate to the thigh and may convey the location of their pain with the C sign, which is performed by the index finger and thumb over the anterolateral aspect of the hip. Common associated complaints include clicking, popping, and catching, which raises the suspicions of a labral injury. Physical examination of the patient with hip pain encompasses gait observation, hip range of motion and strength, special exam maneuvers to help determine the likely cause. A Trendelenburg gait or abductor lurch indicates abductor muscle weakness or insufficiency. The hip range of motion in patients with femoral acetabular impingement typically demonstrates decreased hip flexion and internal rotation, as well as positive impingement sign. A positive anterior impingement sign is marked by pain with hip flexion at 90 degrees and adduction and internal rotation. And this is well demonstrated in the photo. This is for an anterior impingement sign. For a posterior impingement sign, this can be demonstrated by the Faber test, a flexion, abduction, and external rotation test. This sign is present in 88% of patients with an anterior impingement sign. The Faber test, the hip flexion, abduction, and external rotation is performed to assess for labral pathology, since impingement can result in a labrum tear, and this test is frequently positive too. So this is the Faber test, okay? So you have the Faber test and you have the anterior impingement sign demonstrated by internal rotation and flexion of the hip. There may be palpable or audible snapping of the hip, which is detected with the hip range of motion, and this indicates a snapping hip syndrome from either the iliopsoas tendon in the groin, this is an internal snapping, or an iliotibial band along the greater trochanter, and this is the external snapping sign. It is essential to distinguish this from impingement, although both may occur together. The iliopsoas sign will give you a snapping internal sign or internal snapping, and the tensor facial lata or the iliotibial band will give you, due to rubbing on the greater trochanter, will give you an external snapping sign. These you should include in your differential diagnosis when you're investigating for femoral acetabular impingement. Once the history and physical exam confirm suspicion for femoral acetabular impingement or any hip pathology, for that matter, radiographic evaluation of the hip with X-rays is the initial step. At a minimum, X-rays should include a standing anterior-posterior view of the pelvis, an AP of the hip, a lateral of the hip, and I believe a lot in the full profile view. So as to demonstrate the pincer, which is marked in brown, and the cam, which is again in brown. Also, you have to know whether you have, on an AP view, you can tell whether you have the acetabular overlap sign, where the acetabulum is protruding further forward with respect either to the anterior or posterior margin of the acetabulum, whether it's an anterior impingement or posterior impingement. And this often occurs in patients who have a protrusio acetabuli or a acetabula profunda, or depending on the margins of the acetabulum, whether the anterior or the posterior margin is overlapping the other. You should also ask for a frog leg lateral radiograph. Why? Because this demonstrates the cam very well, and it gives us the acetabular angle. The alpha angle, sorry, I apologize. The alpha angle is a line which is drawn in the center of the neck to the center of the hip, and another line is drawn from the margin of the cam from when it starts and to the center of the hip. If this measures more than 42 degrees, then you have to worry. Does this patient have a cam? Does he have femoral acetabular impingement? If it is 42 degrees or less, then it could indicate a normal hip. These views allow the physician to assess the pelvis and proximal femur anatomy. Standing films help determine the position of the hip at a functional load-bearing position, which also helps detect arthritis of the hip or hip dysplasia. Cam and pincer lesions are identifiable on these X-ray views. The lateral center edge angle is also measured to assess for hip dysplasia. The lateral center edge angle is formed by a vertical line from the center of the femoral head and a line to the lateral edge of the acetabulum. It tells us on how deep is the acetabulum. The angle is less than 25 degrees is indicative of a hip dysplasia or lack of lateral femoral head coverage by the acetabulum. This condition is critical to identify, since hip dysplasia can also manifest in intra-articular hip pain. Pincer deformity will present as an excess bony growth along the edge of the acetabulum, and a cam deformity will demonstrate as an excess bony growth along the femoral head-neck junction laterally, or loss of sphericity of the head. Retroversion of the acetabulum can also be a cause of anterior impingement, as this manifests with an overhanging of the acetabulum, which is called the crossover sign, rim and crossover sign on the AP pelvis. Other views commonly obtained to assess the femoral acetabular impingement include the false profile and the dawn views of the hip. To obtain false profile view, the patient standing at an angle of 65 degrees from the cassette as the X-ray beam is directed toward the affected hip. This view can help assess the amount of anterior acetabular coverage of the hip by measuring the anterior center edge angle, and this is measured by an angle formed by a vertical line from the center of the femoral head and line from the center of the femoral head to the anterior acetabular rim. In an angle of less than 25 degrees, I mentioned it's indicative of poor anterior coverage. Pincer deformity will demonstrate an increased angle greater than 40 degrees because of overcoverage, as I spoke about coxa profunda and protrusio acetabula. The down view is a lateral view of the affected hip, which can be obtained at 45 degrees angle to the hip. This view best assesses the cam deformity along the anterolateral aspect of the femoral head-neck junction. The alpha angle measurement determines the extent of the cam lesion and is measured by a line in the center of the neck axis to the center of the femoral head, and another line from the center of the femoral head to the point of the anterior femoral head where normal sphericity is lost. Abnormal alpha angle measurements are over 50 degrees and indicate a cam deformity. Look, this is how we measure the cam. You draw a longitudinal line through the neck, you draw to the center of the head, and from the center of the head to the beginning of the cam. And if this measures more than 44 degrees, then this indicates that there is a significant cam deformity, and these patients will end up having degenerative arthritis. Magnetic resonance imaging, MRI, with or without intra-articular contrast injection, is also utilized to assess femoral acetabular impingement. This imaging modality can provide valuable information about potential labral or cartilage injury from impingement. It also offers three-dimensional imaging of bony morphology and the presence of impingement cysts in the femoral neck. Other possible causes, sources of hip pain can be identified, such as avascular necrosis, stress fractures, greater trochanter bursitis, abductor tendonitis, and iliopsoas tendonitis. So these are all points you have to consider. So the treatment of femoral acetabular impingement of both non-operative and operative surgical options. Non-operative measures should be initiated before consideration of surgery. Such treatment options include physical therapy, activity modification, pain medication, primarily with non-steroidal anti-inflammatory drugs. So there is a consideration for intra-articular injections with a combination of local anesthetic and steroids. This can be helpful for diagnostic and therapeutic purposes, as successful pain relief from the injection would confirm the diagnosis and etiology of pain. If the patient has failed conservative treatment and the pain is affecting their quality of life, then surgical treatment should be considered. Surgical management consists of resecting the bony causes of impingement and repairing soft tissue structures as needed. Surgery can be performed arthroscopically or using an open technique. In the presence of a cam lesion involving the femoral head-neck junction, a cam resection or femoral osteoplasty is performed by using a high-speed burr to shave down the excess bone. When a pincer lesion is present on the acetabulum, an acetabular osteoplasty is performed. By removing the excess bone causing impingement, the patient can have an improved range of motion without pain. It is not uncommon for the labrum to be torn as well as a result of impingement. Thus, when recognized, the labrum can be repaired if considered repairable, or simply debrided if repair is not feasible. Focal cartilage damage can be identified occasionally as a result of impingement. In this scenario, microfracture can be performed to stimulate new cartilage growth. However, this creates fibrocartilage rather than articular cartilage. If hip arthritis is present on imaging, then these procedures should not be performed as they do not address pain from arthritis, and the patient will continue to have pain after surgery. شو نفع تشيل كام أو تشيل البنسر إذا already the patient has arthritis? This is one of the prerequisites you have to do prior to deciding on whether surgery is to be done or not. Thus, patients with hip arthritis and femoroacetabular impingement should be treated for hip arthritis. If severe arthritis is present, then the patient may be considered for hip replacement after conservative treatment is exhausted. Occasionally, patients may present with hip dysplasia and femoroacetabular impingement cam lesions, and both pathologies should be addressed for optimal outcomes. Hip dysplasia is addressed surgically with a pelvic osteotomy to improve femoral head coverage with acetabulum. There are many described pelvic osteotomies, but the periacetabular osteotomy is the most commonly utilized technique in skeletally mature patients by reorienting the acetabulum to increase coverage of the femoral head. Some surgeons will perform both surgeries in one sitting, others would stage it within a week. Traditionally, osteoplasty of the femoral and pelvis has been performed by open surgical dislocation of the hip. However, hip arthroscopy is becoming a more common avenue for achieving the desired outcome with arguable decreased surgical risks and complications. Open surgical dislocation provides better visualization and allows more exposure to perform the osteoplasty. However, recovery is longer because of more extensive soft tissue dissection. Hip arthroscopy is a growing surgical technique in orthopedics that minimizes soft tissue disruption, but it is much more technically challenging. Arthroscopic outcomes are similar to open techniques for femoroacetabular impingement. The differential diagnosis, it is critical to distinguish femoroacetabular impingement from other conditions that cause the hip. So please don't forget about infections, tumors, fractures, septic arthritis, osteomyelitis, soft tissue infections. You have to know everything about the hip to differentiate between pain in the hip and pain radiating to the knee. And this is a prerequisite before surgery, before deciding on surgery. X-rays and MRI are useful tools for identifying these causes. Labs such as CBC, C-reactive protein, ESR can also help distinguish infectious causes. Fractures and tumors are recognized with X-ray, CT scan, and MRI. Serum or urine laboratory tests could also prove useful for diagnosing certain types of tumors. Other hip conditions that are less urgent to address but must be distinguished from femoroacetabular impingement include osteonecrosis, hip dysplasia, iliopsoas tendinitis, greater trochanteric bursitis, gluteal tendinopathy, arthritis, ilioband syndrome, snapping of the hip syndrome, and lumbar radiculopathy. All these you should keep in mind. Osteonecrosis can be identified on MRI with edema and involving the femoral head. If collapse or sclerosis is present, this may be seen on X-ray, CT, and MRI. Hip dysplasia is identified on X-ray as a shallow acetabulum and or poor femoral head coverage. Iliopsoas tendinitis or internal snapping hip syndrome, as I mentioned before, is identified clinically when snapping or popping is heard or felt within the medial groin. Into shuf, the medial groin, the iliopsoas inserts on the lesser trochanter. On testing this hip, if you hear or feel a snap, you should think of iliopsoas tendinitis. MRI findings may show edema at the tendinous insertion of the lesser trochanter in iliopsoas tendinitis. Greater trochanteric bursitis and gluteal tendinopathy often occur together and present with pain laterally over the greater trochanter, often described as a greater trochanteric pain syndrome. They have pain along the lateral bursa. Hip abductor weakness may be present with gluteal tendinopathy or tears. You have to be careful about this. MRI will show edema around the greater trochanter and tendon insertion of the gluteus medius and minimus muscles. In external snapping hip syndrome, the iliotibial band is tight and snapping over the greater trochanter, causing pain and can be diagnosed clinically. Arthritis will manifest with hip pain and evidence of decreased joint space because of cartilaginous wear on weight-bearing X-rays. Spinal etiology is important to identify as well. Lumbar radiculopathy from spinal stenosis can result in groin or hip pain when nerve roots are compressed, usually involving the L1 nerve root. So I'm putting forward a whole differential diagnosis. Actually, you're nearly reviewing all orthopedics in your differential diagnosis. A history of back pain and numbness or tingling in the extremity is important information to obtain. What about the prognosis? Femoroacetabular impingement correlates as a risk factor for the development of osteoarthritis of the hip, since bony impingement can cause soft tissue and cartilage injury of the hip. The thinking is that surgery for this condition could potentially delay, I repeat, potentially delay the onset of arthritis. Since surgery for this condition is still relatively new, there is limited long-term outcome data. More midterm data is readily available, including a meta-analysis comparing open and arthroscopic treatments. What are the complications of this? Complications associated with surgery for femoral acetabular impingement can organize into major and minor complications. Significant complications include femoral neck fracture from excess resection of the cam lesion. You should not over-resect the cam. At most 30%, not more, even less if you can. Abdominal compartment syndrome, when you're resecting it under arthroscopy, you're pushing fluid in the hip, which is going into the abdomen. And there have been reported abdominal compartment syndromes with extravasation during the hip arthroscopy of fluid. During femoral osteoplasty, and resection, recommendations are that no more, I repeat, no more than 30% of the neck gets resected, as this dramatically increases the risk for a femoral neck fracture. Other major complications include pulmonary embolism, deep infection of the joint, avascular necrosis of the femoral head, and postoperative dislocation. Minor complications include hematoma, deep vein thrombosis, injury to the lateral femoral cutaneous nerve during portal placement or instrument passage, temporary perineal numbness from traction. You have to put them with a bar in between the legs and you apply traction. And this could really cause numbness and even palsy, a palsy of the nerve, temporary. They can have also dyspareunia and superficial infections. And don't forget about heterotopic ossification. The most common complications of hip arthroscopy are hematoma, traction neuropraxia. Heterotopic ossification can be prevented or reduced by postoperative non-steroidal anti-inflammatory medications such as indomethacin. Postoperative and rehabilitative care. من هو هيدا؟ الو
دكتور استمر.
اوكي مين عم بيحكي؟ اوكي
خذ المايك.
patient شو؟
استمر دكتور، بس في واحد فتح المايك.
اوكي رح بنطر اللي امتى ببلش.
اوكي دكتور،
شو المصيبة؟
ممكن تكمل محاضرة.
Okay. Patients who undergo surgery for femoral acetabulum impingement will typically experience a rehabilitation protocol that initially protects their weight-bearing status anywhere from 2 to 6 weeks. You have to keep them off or on partial weight-bearing. You have to pay attention so as to avoid having an insufficiency fracture. Protected weight-bearing is done to prevent stress upon any osteoplasty of the femur or acetabulum, as well as protect any labrum repair. Physical therapy is initiated early with the emphasis on passive range of motion of the hip for the first 3 to 4 weeks. Then weight-bearing status is advanced and an active range of motion commences at around 4 weeks after surgery. Between 4 to 8 weeks, strengthening and gait training starts. At 8 to 12 weeks, there is an emphasis on restoration of complete hip strength, core strength, balance, and proprioception. After 12 weeks, there is the incorporation of jogging, jumping, and agility exercises. The goal is to prepare the patient for return to play in sports or other exercise activity. So much for the hip. Now we're coming to congenital dislocations of the knee and patella. Now let's see, there's questions on chat. Let me see what they are. Thanks for your work and help our candidates. Salah Sayyinan, obey to everyone. Any question about Dr. John's lecture? Can we put chat answer kaza kaza? No. No questions. صلاح رح تكمل شو إذا زهقتوا قولوا لي.
لا دكتور، الشباب مستمتعين وممكن نستمر.
عم بعطيهم تقريبا كل البيدياتريكس اليوم.
congenital الواحد يعدي في الاختبار.
طيب congenital dislocations of the knee and patella. Look at this X-ray. Look at where the tibia is in relation to the distal femur. It is anterior. Keep this in mind. Many times you ask the question, if you get a congenital dislocation, describe the position. Is it posterolateral? Is it posterior? Is it anterior? Is it anteromedial? Congenital dislocation of the knee is a rare condition with an incidence of 0.1% or less. It is apparent at birth, and infants usually present with a dramatic hyperextension deformity. Please, if somebody asks you, how would you tell whether it is a congenital dislocation, or at least be suspicious? Then you should mention that any child which is born with a hyperextended knee or an extension contraction of the knee, you should think of it. You should not forget it. But it's true, it's very rare. In my experience, I've had 3 cases over 50 years. This shows you how the child presents. Where do you think the tibia is? The tibia is dislocated anteriorly. The condition can be diagnosed prenatally with ultrasound. Congenital dislocation of the knee is most commonly associated with female sex, premature birth, breech delivery, isolated hip dysplasia, and clubfoot are present in 50% of the time. Bilateral congenital dislocations of the knee is almost always syndromatic or syndromic and is associated with laxity conditions such as Larsen syndrome. We all know that Larsen is associated with multiple dislocation. Beard syndrome, Ehlers-Danlos syndrome due to hyperlaxity of the ligaments. Neuromuscular conditions such as arthrogryposis and myelodysplasia. If such conditions are suspected, referral to a geneticist and on neurologist is necessary. But this does not mean you should not deal with these patients. You should be the treating subject. You should decide what you should do orthopedic-wise with the patient. Mish you refer him to a neurologist and they leave him as such. You can correct and bring these patients nearly to life or enjoy life. Clinically, the femoral condyles are prominent posteriorly. طبعا, it's prominent posteriorly in the popliteal fossa. Why? Because the tibia is dislocated anterior. You failed the femoral condyles posteriorly. The foot may be touching the infant's face or shoulder with marked hyperflexion of the hip. The hip hyperflexes, the knee is hyperextended, therefore the foot may reach the face. Look at the photo below. Look at the foot where it is. If he flexes more, this foot might reach the face. The flexibility of the quadriceps contraction is assessed by applying gentle traction to the tibia while attempting flexion of the knee. Classification and radiographic and anatomic characteristics. You have a grade 1 is shown on the extreme left side. The range of passive flexion is more than 90 degrees, and that is, and they usually have a recurvatum, but the knee can flex. At grade 2, there is subluxation of the tibia anterior on the femoral condyles. So you have to keep this in mind. And there can be some flexion from 30 to 90. And grade 3 is a complete dislocation, less than 30 degrees range of passive flexion. You have to keep this in mind. These are the 3 grades of congenital dislocation of the knee. The classification of congenital knee deformity is based on severity. Grade 1 dislocation is defined as hyperextension greater than 15 degrees with full flexion possible and normal radiographic findings. Grade 2 deformity, there is subluxation, the knee is hyperextended greater than 15 degrees, will not flex beyond neutral extension, and radiographic findings demonstrate that the tibial and femoral epiphyses are in contact with the anterior translation of the tibia on the femur. This shows you a patient with anterior dislocation. I would say it's a grade 3 dislocation because both femoral condyles are present in the popliteal fossa. You can palpate them easily. Grade 3 deformity dislocation, the knee is hyperextended and passive knee flexion is impossible. Radiographs show that the tibial and femoral epiphyses are not in contact and the tibia lies anterior to the femur. Anatomic findings of grade 3 congenital knee dislocation include a shortened and fibrotic quadriceps mechanism, anterior displacement of the hamstring tendons, روح من ورا لقدام, and the iliotibial band, a contracted anterior capsule, loss of the suprapatellar pouch, redundance of the posterior capsule, absence or abnormality of the cruciate ligaments. You have to keep this in mind. These are the findings. These are the pathologic findings that we find in these patients. Treatment should begin as early as possible in infancy. Long leg plaster casting. This is your job and not the neurologist, not the geneticist. Is performed on a serial basis. Every 7 to 10 days, you should change the cast. This process is repeated until the knee can flex more than 90 degrees. At that time, a plastic splint or Pavlik harness can be used until all tendencies for recurrence are overcome. In knees with a more severe quadriceps contracture that prevents effective gradual flexion, a femoral nerve block or Botox toxin injection can be helpful. It relaxes the muscle. The use of botulinum toxin results in long-term quadriceps paralysis that allows gradual stretching to occur. A trial of non-surgical management is appropriate until the child reaches 12 months of age. Surgical management is indicated if serial casting is unsuccessful. Surgical treatment includes lengthening of the quadriceps mechanism with either a VY quadriceptoplasty and or a relative lengthening via an acute femoral shortening. By shortening, you are lengthening. Femoral shortening may be preferred because it minimizes quadriceps dissection and weakening, and also decompresses the anterior skin, which lessens skin necrosis. Because if you have a hyperextended knee and you're stretching it to flex, the skin anteriorly is under strain and stress, and it can slough, it can undergo necrosis. So we're faced with, if you look at the quadriceps, also they are shortened secondary to hyperextension. You have to do a VY plasty to lengthen it, get it down. A way to avoid this is by doing femoral shortening. The iliotibial band is often released from its distal insertion, and the anterior capsule and suprapatellar pouch are completely mobilized. Posterolateral and posteromedial capsulorrhaphies should be performed after excision of the redundant capsule. After the capsulorrhaphies, the knee should have a range of motion from 30 to 90 degrees of flexion. No attempt should be made to gain full extension of the knee. At this point, the knee must be assessed for instability of the anterior cruciate ligament. An anterior drawer test should be performed with the knee flexed to 90 degrees. If the result is unacceptable, the anterior cruciate ligament should be reconstructed with a medial hamstring autograft. The knee should be cast in 45 degrees. It should be casted to 60 degrees of flexion for 3 weeks and then braced to limit full extension for the first 4 months post-operatively. Minimally invasive treatment of congenital dislocation of the knee, mini-open and percutaneous quadriceptoplasty has been described with good short-term results. That terminates our treatment for congenital dislocation of the knee. Don't forget it is anterior. Don't forget that the extensive mechanisms are shortened, like the quadriceps. You have to lengthen them. You have to release the superior pouch. You have to beware and see the function of the anterior cruciate ligament. If it is very unstable, you have to reconstruct it with the hamstring. And that's it. Don't forget, in hyperextension of the knee, the muscles which lie posterior move forward. They become extensors. So you have to do something about it. The best thing you can do is to do some sort of a shortening to relax all. Many times we need to inject Botox to relax the muscle completely, so that we'll be able to get the tibia down and put it under the femoral condyles. Enough for congenital dislocation, congenital patellar dislocation. Congenital patellar dislocation is defined as a laterally displaced hypoplastic patella with severe trochlear dysplasia or an absent trochlear. Look at this patella. You can see it on various views. Over here, here. You can see it. You see that the fossa is not normal where the patella passes. Now, it's very important that you be able to detect these early, but to our unluckiness and our mishap is that many are discovered later on. We don't realize that the patella is dislocated often later on. Another point is that when the patella is dislocated, this tends to pull the whole knee into valgus. So you have to keep this in mind. The condition is often present at birth, but a diagnosis may not be made until years later. It is associated with knee flexion contraction and valgus. A question I love to ask is that if you have a congenital patella dislocation, where would you find the position of the knee? You would see that it's slightly flexed, and you see that the knee is in valgus, and you see that the whole leg is externally rotated with respect to the femur. Congenital patella dislocation is also often associated with the Down syndrome, with Rubinstein-Taibi syndrome, nail patella syndrome, Larsen syndrome. I told you there are multiple forms of dislocation occurring with it. Arthrogryposis congenital multiplex, diastrophic dysplasia, and Ellis-Van Creveld syndrome. You have to keep this. These are all the dysplasias where you have dislocations associated with. Congenital patella dislocation should be differentiated from the more common obligatory subluxation, which develops later in childhood and adolescence. Anatomical and clinical characteristics. Anatomic findings include thickened, tight lateral retinaculum and iliotibial band, a thinned and stretched medial retinaculum, of course, because the patella is dislocated laterally. The extensor mechanism is contracted. The whole tibia is externally rotated. What happens medially? The retinaculum stretches. So you have a lateralized and shortened quadriceps also. Clinically, the child may present with a knee flexion contraction, delayed walking, genou valgum, external tibial torsion, an associated syndrome or condition. On physical examination, the femoral condyles appear prominent anteriorly. Why? Because the patella is dislocated, there's nothing to cover it, so they appear prominent anteriorly. The patella is small and laterally dislocated throughout the knee range of motion. Radiographs often demonstrate an empty intercondylar space on Merchant views. However, findings are often unreliable in patients younger than 3 years because of the lack of patella ossification. MRI or ultrasound may be necessary to confirm the diagnosis. Treatment. Non-surgical management cannot correct a congenital patella dislocation. If the child has progressive functional decline or the inability to achieve developmental milestones, surgical treatment should be considered. Extensive lateral release with release of the iliotibial band and occasionally the biceps femoris should be performed so as to release the patella laterally. You should release the biceps femoris insertion, the iliotibial band. Don't forget this. You have to do an extensive lateral release. If this treatment does not allow for centralization of the patella and extensor mechanism, a VY quadriceptoplasty or an acute femoral shortening should be performed. A medial imbrication is then necessary to maintain a reduction, a medial patellofemoral ligament reconstruction can be performed to augment the medial imbrication. There is no need to close or repair the extensive lateral release. You don't need. I know you'd end up with an empty space, but you don't need to close it. You release all what I mentioned about. You imbricate it medially. If necessary, you do a VY plasty of the quadriceps. And if not, you'll have to do some shortening. Assessment of the distal patella tendon insertion should then be performed. If distal realignment is deemed unnecessary, then you have to transfer a portion of the infrapatellar tendon medially. And this is done by the Roux-Goldwatt transfer, or a patella tendon preosteal sleeve medialization can be performed. In summary, congenital knee and patellar dislocations are rare conditions, and they are often associated with underlying syndromes. Congenital knee dislocation is easily diagnosed during the newborn period because of its dramatic clinical presentation. Treatment with serial casting should begin as soon as possible in infancy. If the result of casting is unsuccessful, surgery is the mainstay of treatment. Congenital patellar dislocation is more difficult to diagnose than congenital knee dislocation, and usually is unrecognized until early childhood, when walking milestones are usually achieved. If the child has progressive functional decline or the inability to achieve developmental milestones, surgical treatment should be considered. Acute femoral shortening is an alternative to VY quadriceptoplasty because it minimizes quadriceps dissection and weakening. The points note: non-surgical management cannot correct congenital patellar dislocation. Surgical treatment of both congenital knee dislocation and congenital patellar dislocation progresses in a stepwise fashion with the goal of obtaining stability of the tibiofemoral and patellofemoral joints to allow functional gait. The last topic I will be discussing is arthrogrypotic syndromes. I would leave this up to the audience. Do they want, are they bored, or what? شو صالح دكتور صالح خالد
اسمعك دكتور، معك.
بكمل او لا؟
لا استمر دكتور.
شو تعبوا او لا؟
لا
شو بدكم؟
ابدا دكتور، الشباب مستمتعين.
طيب يعني بكمل، انا بقدر احكي لبكره على بكره.
خذ راحتك يا دكتور، احنا المستفيدين.
يلا ماشي. arthrogrypotic syndrome. طلعوا بهالولد يا جماعه. Look at the elbows. Just look at the elbows. You see they're fused. Look at the feet. He has club feet. Look at the hips. On the left side, it's shorter, the femur, than the right. These children have teratologic hip dislocations. They are called fusiform joints. Why are they called fusiform joints? Because the muscle is atrophied. The muscle is fibrotic. So the joint is present, but there are no muscles to work on, and this is what they have. So club feet, teratologic hips, knee fusions, knee difficulty in flexion, extension, all these are important findings in arthrogrypotics. Arthrogryposis multiplex congenital, which is also known as arthrogryposis, is an umbrella term rather than a diagnosis for a heterogeneous group of disorders characterized by multiple congenital joint contractures. Although the exact etiology is not known, it's usually multifactorial. The problem is in the nerves, in the muscle, connective tissue disorders. Is it in the maternal? Does the mother have a maternal disease? Intrauterine constraint, meaning that this child cannot rotate within the uterus. Is there a vascular compromise? The condition is associated with decreased fetal movement. The earlier the intrauterine insult, resulting in fetal akinesis. What we mean by akinesis, fetal lack of movement, the more severe the disease is at birth. Most deformities are non-progressive and may improve over time with early treatment. Mental development is usually normal. The most common musculoskeletal deformities associated with arthrogryposis are club feet, hip dislocations. The incidence of arthrogryposis is approximately 1 per 3,000 live births. More than 300 different syndromes are associated with congenital contractures. These conditions are associated with substantial morbidity and economic burden. So understanding the underlying etiology of a child's condition can aid in determining the prognosis and selecting the best treatment options. Approximately 50% of the conditions associated with arthrogryposis have an underlying genetic abnormality. Distal arthrogryposis is one of the most notable conditions because it can be inherited in an autosomal dominant manner. Congenital contractures can be categorized as isolated or multiple. In a child with multiple congenital contractures, it is necessary to determine if the neurologic examination has normal or abnormal findings. This I will not go through. Amyloplasia, and distal arthrogryposis are common types of arthrogryposis that are associated with normal neurologic development. A generalized connective tissue disorder and fetal crowding are less common causes of arthrogryposis that are associated with normal neurologic development. Conversely, an abnormal neurologic examination suggests that in utero, movement was diminished as a result of central or peripheral nervous system disorders or intrinsic muscle release. So you have to notice this. There are two types. One, the peripheral, they are totally normal central nervous system wise, while the ones which are more or less central, they have an abnormal neurologic system or signs, and they have numerous intrinsic muscles proximally. The diagnosis: prenatal ultrasounds may be able to document fetal movements and positions that suggest a typically developing fetus versus a fetus affected by multiple joint contractions. So you have to know that we use ultrasound to identify this. We can always tell whether there is any movement, lack of movement, etc., associated with the condition. Genetic testing may be useful. However, only approximately 50% of arthrogrypotic conditions have an identifiable genetic abnormality. Genetic information can be helpful in counseling parents on the risks for future affected pregnancies. Arthrogryposis is not a hereditary condition, whereas distal arthrogryposis is often inherited in an autosomal dominant pattern. Any child with multiple contractions should have a thorough initial history and physical examination, including family history. If you look at this slide, it's a photograph of a child with distal arthrogryposis with bilateral hand and foot deformity. His mother and uncle are pictured also below. They are also affected, as is this maternal grandmother. This is not pictured, and the photograph of the left hand of the child, the left hand of the mother, and the left hand of the child's uncle are demonstrated. So it's a hereditary. The distal arthrogryposis is hereditary. It is autosomal dominant. Additional studies and consultations with specialists may be warranted if the condition affects the neurologic system or appears to be syndromic. The skeletal survey, including radiographs of the spine, the shoulders, the elbows, the hips, the knees, and feet, is usually obtained early in the examination process. Depending on the results of a skeletal survey, a partial differential diagnosis may include spinal dysraphism, congenital muscular dystrophy, spinal muscular atrophy, structural brain anomalies, chromosomal abnormalities, thrombocytopenia with the absent radius, TAR syndrome, Mobius syndrome, Larsen syndrome, Freeman-Sheldon syndrome. You have to include these when you're studying the patient. Now, I might be told, Hakeem, we don't deal with these so much. But when you're studying basic orthopedics, you should know about them till you graduate. Then if you come involved in this specialty, of course, you should know about it. But we demand that all orthopedic residents should be well acquainted with these problems. What are the types of arthrogryposis? Amyoplasia. Amyoplasia is the classic form of arthrogryposis, comprising approximately 1/3 of all cases. The incidence of amyoplasia is approximately 1 per 10,000 live births. It is not a hereditary condition. All 4 extremities are affected in approximately 60% of patients. Only the lower extremities are affected in approximately 25% of patients, and only the upper extremities are affected in 15% of the patients. Clinical features are often diagnostic, including a midline hemangioma on the forehead, although this usually disappears over time. You can see the hemangioma on the mid aspect of the forehead, and these disappear, but this patient had arthrogryposis. The lower extremities are usually held in a typical posture, flexed, abducted, externally rotated hips, rigid knees, flexed or extended, and club feet. This shows you how the position of a patient with arthrogryposis says. You see that the wrists are flexed. You see that the thumb is in the palm. The thumb on the left is more demonstrating of a thumb and palm deformity. The elbows are fixed in extension. The knees are in flexion. طلعوا هون on the left side, you see that there's no muscle. It's absent or fibrotic. That for this reason, we call them fusiform joints. A typical posture also characterizes a myoplasia of the upper extremity. A myoplasia literally means without muscle, so muscles are typically hypoplastic or absent. In fact, the skeletal muscle is replaced by dense fibrous tissue and fat. Joints lack flexion creases. Look at the thumb where it's present. Look at they lack flexion creases of the fingers. The wrist is flexed. You have to keep this in mind. Intelligence is normal. Sensation is intact. And most affected children are able to function independently as adults. This shows you, look at the creases, it's absent. Look at it, the muscles are atrophic. The knees are fixed in flexion. Distal arthrogryposis most notably affects the hands and feet, but it may also involve more proximal joints. Distal arthrogryposis is often inherited in an autosomal dominant manner. Clinical features are similar to, but less severe than classic hemiplasia. The hands are usually held in a typical posture with flexed wrists and the thumb in the palm. Look at the thumb the way it's in the palm. And usually they have flexed wrists. The lower extremities may exhibit hip dislocations. They are teratologic, they are rigid, difficult to reduce. Club feet, they also have congenital vertical tali. The joints are notable for lack of flexion creases. These patients also have normal intelligence, intact sensation, and most can function independently as adults. What about Larsen syndrome? Larsen syndrome, which was originally described in 1950, is a rare hereditary syndrome characterized by multiple joint dislocations from birth and characteristic facial features. The characteristics of the syndrome include a flattened dish-like face, bilateral dislocations of multiple joints, equinovarus deformities of the feet. Look at it. This is a patient with Larsen syndrome. They have multiple dislocations. They have club feet also. Mutation occurs in the PLNB gene, which encodes for protein filament B and acts as a cytoskeletal binder to help chondrocytes differentiate and proliferate during development. The disease is characterized by a combination of laxity and dislocation in large joints that is present from birth, most commonly the cervical spine, the hip, the knee, and radiocapitular joints, and rigid talipes equinovarus deformities of the feet exist. The cervical spine and knee deformities are particularly challenging to manage, and the goals of treatment are stabilization and prevention of further deformity. Unilateral hip dislocation are often treated surgically, but the treatment of bilateral hip dislocation is controversial and may be best left untreated. Clubfoot deformities also are challenging to treat. Similar guidelines to the treatment of club feet for other arthrogrypotic syndromes should be followed. The timing of treatment usually involves serial casting for club foot, followed by surgical stabilization of the cervical spine if necessary, and then treatment of knee and other joint dislocations. The Bruck syndrome, I just want to mention it briefly, is an extremely rare syndrome with approximately 20 patients with this condition reported in the medical literature. I know I'm going to be attacked. Why are you telling us when there's only 20 patients? You have to know just one thing, that this syndrome is a combination of arthrogryposis and osteogenesis imperfecta. If you know this much about Bruck syndrome, that's what I would accept. There are two subtypes. They have been identified with different gene mutations, but similar phenotypic presentations. And this condition manifests in neonates with multiple joint contractions and pterygia. Fractures are often seen in postnatal period. Most patients are non-ambulatory because Bruck syndrome is challenging to treat. Realistic goals should be discussed with the patient and the family to achieve satisfactory outcomes. This is a patient with Bruck syndrome. General management, although each child with arthrogryposis is unique and requires a personalized treatment plan and goals, many management principles apply to most patients. Clinicians should aim to maximize function while minimizing repeated hospitalizations or medicalizations of these children. Inaccurate diagnosis will help parents understand disease risk in future pregnancies. Some families may require counseling to deal with feelings of guilt, especially if the mother believes the condition is related to the size or shape of the uterus. Local and national arthrogryposis groups can provide valuable support to patients and their families. Physical therapy and a stretching program done at home should be started as soon as possible. Stretching should be gentle. شو راح هيدا؟ شو القصة؟ Okay, I will
دكتور جون؟
terminate. شو بدكم أوقف؟
لا دكتور، هو السكرين راحت من عندك.
يلا. The stretching program done at home
Okay.
should done at home should be started as soon as possible. Stretching should be gentle and atraumatic. Stretching can be quite effective in reducing contractures, especially in children younger than 1 year. Bracing may be necessary to provide joint stabilization, which can encourage the achievement of normal developmental milestones. Lightweight non-articulated ankle-foot, knee-ankle-foot orthoses are also used. Bracing is also vital to maintaining any joint range of motion. So you have to keep these in mind. Surgical correction should be reserved for enhancing function, not merely correcting deformities. Surgical intervention should be delayed until the child is demonstrating head and trunk control, which are indicators of the future ability to stand. The number of hospitalizations, this is very important, and periods of immobilization should be minimized to allow normal socialization and education. If we want to do procedures, we like to do them combined. Hip extensor strength is mandatory for upright stance. So surgical correction of knee deformities may not be indicated if the child lacks the strength to stand. Surgical intervention for the upper extremities should not be considered until the child demonstrates difficulty with activities of daily living. Even then, the child's function may improve more with occupational therapy than with surgery. The use of anesthesia in patients with arthrogrypotic conditions, I want to warn you this, requires special consideration. Trismus, cervical spine stiffness, or laxity in patients with Larsen syndrome, difficult intravenous access, gastroesophageal reflux, and postoperative airway obstructions are common in these patients. One type of pterygium syndrome is associated with malignant hyperthermia. The spine and lower extremities, scoliosis and arthrogryposis has been reported to have an incidence of 70%. Curvatures in these patients may be present at birth and often progress as the child grows. This shows a growing rod being inserted so as to maintain the correction and prevent it from progression. At an early age, we don't like to operate cases, especially at congenital curves. The reason why is we found that if we do a fusion, this affects the amount of alveoli, and the patient would die from respiratory insufficiency at a certain early age. Most curve patterns involve the thoracolumbar or lumbar curves with pelvic obliquity, but also can involve the thoracic spine. Most patients with arthrogryposis and scoliosis do not have congenital vertebral anomalies. However, congenital scoliosis with upper extremity arthrogryposis has been described in a small series of patients. Although the use of a thoracolumbar orthosis in these patients is often unsuccessful, it may delay the need for surgical stabilization. Medical literature provides little guidance for the treatment of children with arthrogryposis and scoliosis. One study found that non-surgical management of curves may be effective for ambulatory patients who have less than 30 degrees of curvature. However, it is unclear how many of the curves would have progressed with without brace treatment. Of the patients who required spinal fusion from the same study, 30% were non-ambulatory and had involvement of all four limbs. Combined anterior and posterior fusions was recommended for this population, but this was prior to the widespread use of all pedicle screw constructs and posteriorly based osteotomies, which have much more corrective potential than the older technologies. Traditional spine-based growing rods or rib-based distraction using implants such as vertical expandable prosthetic titanium rib are viable alternatives to bracing in patients with progressive early onset of scoliosis. However, in a series of patients with arthrogryposis and early onset of scoliosis who were treated with Vector, a 60% incidence of proximal junctional kyphosis was reported. As with all growing spine implant systems, complications were frequent, and at least one complication was seen in 40% of the patients. Newer growth modulation techniques include magnetic expansion control technology. Device are promising. This is by means of electromagnetic, and it saves us from going in several times to expand the spine. And they can be lengthened externally, which decreases the number of surgical procedures the child has to undergo. However, complications can occur. A recent study reported a 42% rate of unexplained returns to the operating room in non-arthrogrypotic patients treated with growing rod surgery. Hip dislocations, the management of bilateral hip dislocations remain controversially because surgical intervention can cause hip stiffness and osteonecrosis. Closed reduction is rarely successful in these patients. Unilateral dislocation will result in functional limb length discrepancy, and if surgery is elected, the hips should undergo reduction in infancy, and post-operative immobilization should be limited to 5 weeks to minimize the risk of post-operative stiffness. Although a risk of osteonecrosis exists with medial open reduction, the limited surgical dissection required with this approach compared with an anterior approach minimizes the risk of increasing inherent joint stiffness. In the long term, a stiff hip may be more debilitating than a dislocated hip or a collapsed femoral head. Hip external rotation contractures of the hip rarely requires surgical intervention. In fact, surgical dissection around the hip should be avoided to minimize the risk of joint stiffness. If external rotation of the limb is problematic, interfering with gait or wheelchair sitting, it can be addressed through a distal femoral derotation osteotomy. Knee flexion contractures, early stretching may improve the arc of motion in the arthrogryposis. With knee flexion contraction, casting or bracing should be used to maintain the range of motion. All the children who have not been successfully treated with casting or bracing may require hamstring lengthening, release of the gastrocnemius, origin, posterior capsulectomy, and even femoral shortening via popliteal fossa approach. Now, I'm going to skip many things. It's very important to use the brace as to prevent stiffness in these patients with arthrogryposis. I just want to mention a few things before, and I am getting really tired. If you recall over here, this is a patient who has arthrogryposis. His knees were stiff. He had severe club feet. So what was done was a knee disarticulation, and this is how he's walking. This is another patient with severe club feet in a patient with arthrogryposis. These are rigid to treatment. You have to start them from the very first day of birth to correct them by casting techniques. Later on, you might have to do surgery. And in these patients, older children, if they're very stiff, we're doing even talectomies. So you have to keep this in mind in arthrogryposis. Talectomies may be an appropriate salvage procedure for older children who have substantial residual deformity. This procedure is often delayed until most of the foot is completed at approximately 10 years of age. There's a congenital vertical talus. Many of these children with arthrogryposis are born with a congenital vertical talus, and is the most severe form of pathologic flat foot. This deformity is usually associated with other conditions such as spina bifida or arthrogrypotic syndromes. As in club foot, some correction may be obtained by serial casting. However, many patients with this type of stiff foot will require open reduction. So, the upper extremity is also involved, and many of these children will have a internal rotation of the shoulders as if they're asking for a tip. The waiter's tip, and they would have an internal rotated shoulder, adducted pronated forearms, just as occurs in brachial plexus palsies. So look at this child. He's sitting, his wrists are flexed, and they're internally rotated. He cannot get his hands up so to reach his mouth. So what we do is we do a proximal derotation osteotomy. So you have to keep this in mind. Elbow flexion is the most critical element in obtaining independence in activities. We do operate, we do lengthen the triceps in these patients. We do releases so as to get flexion. Many times we do muscle transfers and tendon transfer. The whole purpose is to get the hand to the mouth. So you have to keep this in mind. The shoulder we spoke about, the elbow. This is working on the elbow, lengthening the triceps through VY-plasty, working on the whole elbow to get some flexion at 90 degrees, but we have to activate it by doing some muscle transfers. The ulnar nerve is identified, we translocate it when we do this procedure. We do a VY lengthening of the triceps. Okay, so you have to keep these in mind. These are procedures we do on this. The wrist, if you look at the wrist, they are mostly flexed. I'm going to show you. The wrist is flexed many times in this position, and you can have fused carpal bones. So what we do a dorsal wedge resection, and we extend the wrist, and we put 2 pins to hold it until they unite. The whole purpose is to get the hand to face to his face. Okay, and in addition, we correct it, not only the extension, we can correct ulnar deviations to radial deviation. Okay, we do a biplanar wedge resection from the dorsum of the carpus. Look at, also they have a thumb and palm deformity. Then you have to do multiple releases. You might even have to do a tendon transfer so as to get the result. So this is the result. You have to also work on the skin because the skin is contracted. Okay, I'm sorry I'm going very quickly, but I'll tell you I am tired. So let me say, key study point. Let's see. Arthrogryposis is a constellation of different diseases with a similar phenotype of non-progressive multiple joint stiffness and contractions. treatment of patients with arthrogryposis focuses on improving a patient's function with as little hospitalization time as possible. Physical and occupational therapy should be used to minimize or obviate the need for surgery. Surgical treatment should focus on improving function, not necessarily on correcting deformity. Both the surgical and non-surgical management of upper extremity amyoplasia should focus on enhancing the patient's ability to complete hand-to-mouth activities. The creation or maintenance of an appropriate thumb index web space is important for single-handed manipulation of objects. Thank you very much. خالد في شي أسئلة؟ يمكن زهقناكم. شو يا شباب؟ زهقناكم؟
لا بالعكس يا دكتور.
إن شاء الله ما تكونوا زهقتوا الآن. أنا بقول لك I tried to make the best out of this lecture and to include many pediatric conditions. إذا بتتذكروا هيديك المرة we discussed CDH or DDH. We discussed patients with slipped capital femoral epiphysis. This time we discussed the same, the Legg-Perthes disease. These are certain topics that we like to deal with in the board examinations and knowledge. Now, the next time we will discuss fractures and we will discuss the shoulder and proximal humerus. Okay, thank you very much.
شكرا دكتور على المحاضرات الممتعة.
يلا باي باي.
الله معك. الله معك دكتور، مع السلامة. في أمان الله. دكتوري